forever in my life.
The floor is yours, Dr. Bennett.
Good morning. Wednesday morning, September 29th. What better way to celebrate and hump day than to get together and learn a little something about the world? So first, we'll start with the usual housekeeping. If you want to get CME credit, you want to make sure that you are logging in to this session. You can type your name into the chat box, or you can use your QR reader in the New Innovations app on your phone to go ahead and hit that little badge buddy and get registered. Remember too that we want to get your CME forms back within 7 days of this presentation in order to count you. So please go ahead and jump on that as soon as the presentation is complete. I hope everybody brought your passports because today we're going overseas. I hope that as far as you've got your coffee and I'm looking out across a room of residents and students, and once again, one attendant. He's a stalwart. Dr. Moracle's all right. Welcoming all the other attendings to join us again at Pierce Conference Room. Today, we have Dr. Curtis Carey, who I've known forever. I've known since 2004 up at the University of Kentucky. He went to medical school and medicine pediatric residency there, was chief resident in both pediatrics and in internal medicine while he was there. And subsequently led the medicine program as the program director. And then here, he fell into the same trap. So Curtis has been part of this international medical service for a long time. And so this has been a passion of his, and I'm really, really thrilled that he's here to share with us some of the lessons he's learned. And accompanying him is Dr. David Sharon, or as it says on the slide, David Sharon. David went to American University College of Medicine down in the Caribbean. So he's now in his second year of residency and aiming his career toward critical care. So without further ado, I'm going to let them jump in and share with us what they learned when they went to Ecuador. Have a good one.
Thanks, Dr. Bennett, for the introduction. Like you said, my name's David Sharon. I don't know where this extra R came from, but this was our basically experience as we went down to Ecuador for a global health trip. And so my portion will be the first half of the presentation, and then Dr. Carey will follow up the second half with more of the academic side of the education. Mine will be more fun and picture driven. Or it won't work, and we won't be doing anything. There we go. So this is a group of guys that were there, and we're standing on the top of an active volcano, which was kind of cool. And I couldn't put the size in perspective, but there's a whole city that lives in the crater of this active volcano. So it's very large. These mountains surrounding it are actually not individual mountains. They're the crests. Like if you think about a volcano, those are just the crests around it. So it's kind of cool. So Global Health Elective is available to all of us. If you're interested, Dr. Carey goes. If people are interested, you can do it as a whole block. It involves 10 days between travel and in-country activities. And then 5 of which are clinic-based, kind of some long days because of travel and some other things, sometimes 12, 13 hours. And then typically there's 1 day of like an in-country cultural immersion, kind of more fun activity or rewarding for kind of your long trip and everything else. And then at the end of that, when you come back, there's some modules that we do that's through the Global Health Learning Center, which is a partner with the USAID organization, which is just an international organization, non-government organization that does international work for lots of things, food, medicine, all kinds of things. It's a division of the UN. So this is Ecuador. I don't know if anybody knows me. They know that I've done quite a bit of traveling, and this is possibly one of the prettiest countries I've ever been to as far as natural beauty. Lots of mountains everywhere. You're actually in I didn't know when I went down, but you're actually kind of at the northernmost tip of the Andes Mountains as you're coming up the western side of South America. There is a video here. Sorry for the loud noise. The video, I put the video in mostly because I knew it would stop right here. And I wouldn't say all of it. In the big cities, you're going to have very paved roads, looks very developed. And then once you get into more rural parts of the country, which is a lot of the country, this is all of the travel will be all through dirt roads, very bumpy. And so some of our trips out to the travel sites could take 2 to 3 hours because we're in a big travel bus driving on these very tight, narrow dirt roads. So, and that's just to give you an idea of some of the infrastructure and things in Ecuador. So there's more pictures. This is a picture off the bus. And this is as you're coming from Santo Domingo, or not from Santo Domingo, from the airport in Quito to Santo Domingo, you'll drive through the mountains to get out there. And this is like possibly one of the best parts of the trip when it comes to visuals, because it's an hour and a half of driving through the mountains and seeing all the mountain ranges. And talking about some of the bus drivers and some of the people who have been before, we'll talk about how if you think about it, like the Incans and all of these ancient civilizations walked these mountains to traverse and spread their civilization outward. So, and here's a waterfall that we stop at on the bus trip in, kind of as a break for the people who might be a little more motion sick through the windy roads. Keep pressing the wrong arrow key. So this is another picture I brought in. This is just to give context. I've been to a lot of places and I've lived in a lot of places. And I don't know, I've seen a lot of poverty in the world, but I don't know that I ever saw it to this extent. And these are like just kind of some generalized pictures, but other parts would look way worse. But this is I think they told us at one point that many families live on like dollars a day, like a couple dollars. Like we're not talking about, $10, $20. We're talking about like single dollars per day. And a lot of these markets exist kind of alongside the road. There's not a lot of like, unless you're in like the big cities, Quito and these things, there's not a lot of like built up what you would think of here as far as housing, et cetera. It's a lot of kind of, not haphazard, that's not the right word, but kind of just things that are put together. Obviously you see the sheet metal siding that's used on the tops and people put it on the sides of their houses, and it's a lot of open air living. There's not a lot of air conditioning, et cetera. So, but I was hoping that picture would show a little bigger. Something as we're driving in that I thought was really awesome that I think is new-ish is this playground that is near one of the clinic sites that was put up here recently that actually includes kind of like a little workout area. So there's actually like a chest press and a squat machine and things like that. So something to give people active and something to do. So cost, there's lots of costs involved in this. The cost to us and part of what I'm presenting to the residents is your opportunity and what to expect. So it costs $1,200, $11.95. How we come up with that? Looks cheaper, I guess. Costs $1,200 to go on the trip, and majority of those funds are how they help, and Dr. Carey will talk about later the importance of this, but how we help maintain the freestanding clinic that stays there year round. So there's 3 brigades per year. There's one spring, summer, fall, or something essentially. But 3 times a year they'll go. And so how many? There's probably 50 of us that went. So each time there's somewhere between 40 to 60, and they all pay this. And the majority of that fee goes to the clinic to help maintain medicines, clinic supplies, staffing the clinic, et cetera. So that's where the majority goes. And then you buy your own flight, somewhere between $500 and $700. Dang, Ashley's not here. Dr. Garcia, maybe you can help me out. I was able to, and I just wanted to pass this on to the residents. I was able to receive a travel grant from the Children's
Chattanooga
Foundation
Pediatric Foundation.
that Dr. Woods is a part of, and they were able to extend a travel grant to help subsidize some of this cost. So it was a nice gift from them, and I'm very appreciative because as a resident, we don't have $2,000 extra laying around. So it was nice, and I'm very thankful. And so the rest of the money, and I didn't get a total breakdown. I wasn't privy to that information. Dr. Carey may have a little better idea, but it involves the travel to and from the sites, because the entire time you're there are two like big tour buses that take you around. The accommodations, which are here. This is an old convent that I'll show again in a second, that they use kind of as a conference center now, essentially, although I think we're one of the main visitors to it. And then also all the meals are provided. Well, 90% of them are provided. They give breakfast every day. Lunch is usually provided at the site, and then you get dinner every night when you come back. So this is accommodations. This is Casa Santa Rosa. It's an old convent that's been converted into like a Catholic retreat center, and so different groups will come. There, I believe, was another international health group that used to come and stay there occasionally, but it's dorm style living. So you can kind of see here, there's a door. There's kind of all the way through here. It's just a lot of dormitories. Some are singles, some are doubles, some are triples. And so that's how that goes. And then, like we talked about the meals already. Ombro is the clinic that we work with and are part of. So you basically alternate, because the group's so large, they essentially break up half of you go to the freestanding clinic every day, and the other half will go to some other clinic site out in the community, usually more rural. Many of those involve the Sakshala people, which we'll get to in a second, which is an indigenous group in the area. But this is the clinic, and this is kind of how it's set up. There's a picture later that will show the freestanding building, and then outside they had like eye exams and vision exams. They had, this year, I think was the first year they had psych. Some of the students from another education system came in and brought that. And we also had legal services offered there this year. There's PT that's offered there. And then this picture at the top is the kind of makeshift pharmacy up there. So after they go to the clinic, they get free meds to do that. So, and those were our UK College of Pharmacy students that participated in that. Here's some of the clinic sites. This is at one of the Sakshala villages that I went to. This is a large soccer field. And so those are actually the bleachers, which I thought was kind of cool. Soccer is obviously a big thing. The second one here is another clinic site that was essentially an outdoor recreation center in the community. And they actually did a really good job setting up when we got there. They had all of these rooms like curtained off underneath some shelter. The pharmacy was actually up there under that big like atrium. And then I don't know how many of you can tell in the picture, I'm sure in Zoom people can see it better, but there's kind of like a volleyball looking net there in the kind of forefront of that picture. And that is actually a very popular game in Ecuador that's very similar to Ecuador, or it's very similar to volleyball, but not quite the same. And then the last one is at the same Sakshala village as the first picture, but it's actually like the huts that many of them like live in. And they converted some of them to be our office clinic sites. And so they were converted for that purpose. Some cases that we had, I know this picture is kind of gross, but I thought it was the most interesting thing that I saw. A lot of stuff that we normally see here, and then we saw some infectious disease things, including worms, dengue, chikungunya, those kinds of things you can see. I saw a kid who had some, he came with his cousin. He was 14, his cousin was 10, and they looked identical. And he clearly had some growth delay that needed to be worked up. Unfortunately, all we can do is refer them to a, like an intermediary or like tertiary type center to do that. And that's part of what makes our brigade a little different, how Dr. Carey will talk about how you have a successful health brigade to go out to these things is by having the follow-up. That's the key, not just coming in, dropping off money and medicine and then leaving. Vitamin deficiencies, lots of normal well child exams. Many people just want to make sure that their kid was doing well. And then this was a Stephen Johnson's-like reaction. This kid, we believe, had dengue, and there, if anybody's been to foreign countries, a lot of pharmacies are a lot more unregulated, and pharmacists don't necessarily have to have training, and it's more like a convenience store where you can get lots of things. And so this kid had a fever and a rash and was prescribed amoxicillin, and then about 4 days after finishing, developed this like sloughing of the skin in his fingers and toes. And it started to heal by this point, but it was a lot worse. And so it was kind of an interesting reaction. It was on both his fingers and toes, but nowhere else. So Big thing that they talk about, and something that I think we do a really good job here here at Erlanger, is having multi-professional teams. So this is some of them. This gentleman here is the full-time clinician that's always there. There's a couple other people that are full-time employees that are always at the clinic. And then there's translators there, some physical therapists, lots of nurses, nursing students, pharmacists, pharmacy students, physicians, med students. So there's a huge team that's involved in this. Every single provider and every single department had their individual translator to help with those things. So it was very nice setup, and a lot of the med students helped do different things. Some did nursing things, some took vital signs, some basically acted as scribes to help us get through patients a little faster. They actually have an EMR down there. Even when we went out to the rural parts, they basically set up an intranet so that we could do the EMR. And then when they got back to internet, it would all upload to their system, which I thought was really cool and a nice way of being able to do things like that without having true internet access. The Sachila people are an indigenous group of people that live in Ecuador. There are, I believe, like three main communities left. They are very rural and off by themselves. Like, it takes a while to get to their villages, and they don't intermingle with society much. In fact, they're at one of these villages, there is a large, greater than what you would normally see, albino population, because there's a lot of intermarriage and things like that. And so that gene has been passed down. So in this first picture on the left, they're doing, they kind of showed us like a more ritualistic dance that they do. The females all wear these rainbow skirts, and one of the chiefs was telling us because they're beautiful. And then males all wear the blue and white skirt up there, which is about strength and power and protection. And then the gentleman at the top there that's putting stuff in his hair is actually the achiote pepper. And they grind it all down so it makes a red pigment, and then they add water to it and they put it in their hair, and it'll look down like the gentleman at the bottom. And it gets kind of crusty and pasty after a while. So it's kind of like a red gel, the best way to explain it. But that's something that they used to do, and it helps protect them, like historically and culturally, it helps protect them from like bad omens and things like that. So, and then this bottom right picture is one of the chiefs telling us about some of their older like artifacts from their culture, some going back to, at least told to us, to like the early 7th century or so is where he was getting at. And then the plants and things just to the left of those objects are some of their cultural and historical medicines that they would use. Some things they chew on, some things they grind down and make into like a stew, and then some things they make a tea out of. They also talked about getting closer to their like otherworldly like out-of-body experience type things, using ayahuasca to get in touch with their religious beliefs. And then the top picture is just some music that they had, some kind of local music and instruments. So Mindo is a place that we go as part of our like day of excursion and cultural immersion. It's a little more developed city. They have different travel excursions if you were going on any vacation, things like that. And so I ended up doing zip lining, and I went horseback riding, which are those pictures on the right. And then maybe this video will play, hopefully not too loud. But this is me zip lining upside down through the rainforest, and there's like hundreds of feet below me, which is pretty exciting and fun. So kind of a nice reward to this trip. Big thing Ecuador is known for is chocolate. So one of the things when I went to Mindo was they do a chocolate tour. This picture on the second picture is the cocoa, like bean, not the bean, but like the cocoa fruit, I guess, that we make chocolate out of. And this white stuff is actually, will be eaten raw. So you can take it out. It's really slimy, kind of looks like snot, but it is really sweet and very tasty. And so you just put it in and you suck on it. And then, so that's like kind of the pulp, I guess, if you will, of the fruit. And then you don't eat the bean. The bean's really bitter. It's like essentially eating 100% dark chocolate. And then, so then the process, they take those beans, they dry them out till all the pulp falls off. They wrap them in banana leaves. they ferment for like 3 days in an open air thing, and then they kind of move these down. They roast them, they grind them, and then that used to be the end product. So they would get this very, very 100% dark chocolate, and they would just drink it, kind of like you would make coffee, essentially. And it was very bitter. When the Spanish people came to South America, they didn't enjoy it, so they actually added sugar and then milk, and then they essentially made hot chocolate. So now they've refined that process, and Ecuador is actually the kind of capital, if you will, of all of the chocolate in the world. So these cocoa beans only grow in a specific latitude, and these are the ones, if you talk about like really expensive chocolate, these are the ones that they'll use for that. And the cocoa beans that are specifically grown in a small part of the Andes Mountains supposedly will absorb flavors from around it. So they plant it next to citrus trees, et cetera, so that the chocolate will absorb the flavors around it. So I thought that was kind of cool. And then the last day is on our way back to, it's actually not Santo Domingo. I totally made a mistake there. It's Quito. On the way back to Quito for your travel day on the last day, we stopped. There's a church here that you can go to. It's a basilica. It's absolutely beautiful. One of the prettiest churches I've seen. And then this picture at the top here is actually, it's supposed to signify the equator, but it's actually slightly off. And so they kind of tell you the story as you're going over there about how they came up with it. And there was like a difference between an exact like an exact equator and then the magnetic equator. And so it's actually up on top of the mountain is where the actual equator is, off in the distance. But that's where this huge statue was erected. Ecuador equator, kind of symbolic. Down the bottom right, this food thing that is in the middle, I would love if someone in the audience could guess what they think that is. Is a very, what is it? It is guinea pig. So guinea pig is a delicacy in Ecuador, and I was not leaving Ecuador without trying it. So I had guinea pig. This is, best way to put it, this is a nice way to serve this meal. So this is like at a like kind of a gastro pub type thing. Oftentimes, if it's eaten by the local population, it is literally a guinea pig that's fried and put on a plate. So it'll look like a squirrel essentially on a plate. So this was a little better. The meat's been taken off of the animal. It's been wrapped. It's sitting on a bed of mashed potatoes. So this is a little different, but I was not leaving till I tried it, and it was okay. I don't know that I would order it every time, but it was an experience. And this is where Dr. Carey takes over with some of the academic objectives that we try to accomplish.
Good morning. One of the things that we wanted to emphasize with this, and I think Dr. Garcia and my conversations with her, we would like to encourage people to stay active in what makes them have passion for medicine. And we get a lot of applicants in both pediatrics and internal medicine that have an interest in global health. It's a buzzword on some of the discussion boards, and we want to have an alignment with what our incoming residents and our students want to do. And having these global health experiences is one of the things that I think really is hitting that altruistic vein of wanting to help people and wanting to have that international reach. Pediatrics is a wonderful expression of dedication that is appreciated throughout the world. So I think that if you're interested, please let her know or come talk to me. And we definitely want to meet your own kind of desires in branching out. This is one example. There's others. We chose this one because I had experience with it, and we want to make sure that we align with people that have an infrastructure to where you go out of the country and you have a well, for lack of a more pretty word, taken care of experience. So as David was saying, this is not just physicians. This is a group of people that span multiple states, multiple continents, and partnerships with medical students and health professionals in Ecuador. So this is a truly once in a lifetime kind of thing to where you can work with people of different backgrounds, different experiences, different ethnicities, and appreciate how we can come together and serve our patients that we see. A lot of interest in the last 2 or 3 decades have come out of people wanting to do global health, and a lot of places will offer short-term or long-term experiences. sometimes it's better to kind of get a little background on that. So I pulled a book that I thought that could be helpful to anybody that wants to read more about global health. It's called Hoping to Help: The Promises and Pitfalls of Global Health Volunteering by Judith Lasker. And then I thought that watching kind of this could help. Hopefully this works. It doesn't work. It's a pop-up from a pop-up.
I don't know if it'll show to them because it's sharing the PowerPoint, but everybody here will be able
The
to see.
title is really important. It's called Hoping to Help. And it's about the many organizations and individuals who do volunteering overseas in the health area. And we really want to help people in poor countries to improve their lives and their health.
Oops.
The book helps us to think more critically about the negative impact that global volunteering might have. It's a great concept, but when it's not done properly, it might actually have negative outcomes.
People have assumptions about either it's really good, or in many cases, you find people writing about how terrible it is. You know, there's the Instagram series on Barbie Savior, and there are various articles and blogs about, you know, the white savior complex and how terrible this whole thing is. And I think unless we can show with some good, strong research what the benefits are and what the problems are, then we're just going with sort of opinion.
When volunteers are really prepared and they take into consideration or leverage the resources of their host, everything goes smoothly. But if they don't really, take into consideration the resources and the skills that the host community already has, you could be, duplicating resources. You could actually really have no clue as to how, global health works in a community that's different from the US.
But the question I asked everybody was, well, how do you know if this is valuable? And in many cases, the answer was, well, we just know it. We assume it. Of course it's valuable, And they hadn't really thought about trying to evaluate it. So the assumption that it's a good thing to do and the way in which it meets lots of different people's needs and interests are some of the barriers to improving the whole enterprise in a way that most people agree should be done.
So we want to create and craft an experience to where we understand some of the limitations.
As I wrap up my first month
How
as
do you
president
shift
and
that?
look back on the many conversations I've been having with members of the Lehigh community,
This
I
one.
wanted to share some reflections. First, thank you all for the warm welcome. Students, faculty, staff, alumni, it hasn't mattered. I've been struck by your generosity
While we have
and a number of times.
my technological limitations, here's a quick note of caution when you travel with Delta or any flight. If your plane has an avian encounter, the FAA has changed how to go about evaluating that, meaning that you have to have the mechanic or whatever more elaborate term the airline industry uses come and evaluate the wing and go through 11 pages and 86 items. And in Chattanooga, sometimes he's on his farm 20 minutes away. So Delta thinks, oh, in 20, within 45 minutes that can happen. In Chattanooga, that's a no-go. That's a 2 to 3 hour experience. In Atlanta, if they hit a bird, it's a much easier experience. But if you have an avian encounter here, either we have to take into the migratory patterns of the avian inhabitants of the area, or you're just going to get delayed and come a little later and take your own taxi over the Andes and get motion sickness. So a lot of these groups have been around for a long time, but over the last 2 or 3 decades, we've had tremendous growth in non-governmental organizations and university-based international activities. Some of the people that have been doing this for quite a while, I put on this slide. Catholic Medical Mission Board dates back to 1912 and has worked in over 120 countries. Project Hope launched at traveling hospital ship in 1958 and has taken it over to 30 countries. And Operation Smile, which a lot of us are familiar with, was founded in 1982 to provide cleft palate repair and surgical training in more under-resourced countries, expanding to more services to cover dentistry and burn care. So there's a lot of players in the game. There's a lot of interest and a lot of money. When you look at sponsors for these short-term global health experiences or long-term ones at that, there are 4 major sponsors: faith-based organizations, non-governmental organizations, which are typically in the literature called NGOs that are not faith-based, educational organizations, and corporate groups. We thought that aligning with an educational organization that has experience in educating medical professionals and going into these communities was best for the residents and the students that we would come into contact with. So that is our alignment, but you will see and have opportunities with other sponsoring programs. A lot of these can be arranged into one shot or occasional visits. Some are for a specific thing like cleft palate repair. Some are for primary care education or training. Some have a little bit more longitudinal structure and longevity. They can be periodic but regular visits for screening and preventative care, or they can have an element of year-round operations with bringing in people in boluses throughout the year, which is what the program that we align with has done. When you look at what makes a program successful, in Dr. Lasker's book, she will talk about 7 things. The big one that sticks out is probably a new kind of use of a word is this mutuality. And then one of the noted global health researchers described it as a deep reciprocity that is based on a solidarity among equals. The knowledge and expertise of the community members and partners must be valued and appreciated as indispensable. And then you have to have this continuity. You have to see what is needed and not have assumptions. So a substantive needs assessment, and then you have to involve those host community partners. You have to evaluate our process and outcomes and incorporate those evaluations into improvements, much like what we want to do in healthcare systems here with quality and health delivery and safety. Focusing on prevention is always key, and then integrating diverse types of health services, getting that local capacity, strengthening your volunteer preparation, and having people stay longer are all key things. When we look at our alignment with our partner, we think that it manages to meet most of these, but could be better in some of the evaluation of process and outcomes. So as we look to move forward with our shoulder-to-shoulder alignment, some of the expertise that we can help them with is maybe some evaluation and some integration of practices that could continue to help grow and help solidify some of our mission for our host community. There's also been mention of doing things for the wrong reasons and remembering that you want to first do no harm. This is a listing of 7 things that a group of surgeons from the Uniform Health Services created. And I think it points to some of the issues in that video. You don't want to leave a mess behind. You want to make sure if you bring in technology that it matches the needs. Donating expensive equipment without training, without kind of infrastructure, resource management is not necessarily going to improve or reach the outcomes that you would hope it would to. People don't talk and they don't cooperate and they don't help each other. Imagine that. Failing to have a follow-up plan, and then distractions, politics, lack of training, or kind of off-center training or distracting goals, overriding service, but branding it as service, showing up somewhere that you're not wanted or needed, and then not having that mutuality is definitely one of the things that doesn't engage in the host community and help your mission. And then you have to make sure why you want to do this is well thought out. And some of the things that we frequently encounter is because it's a buzzword, isn't probably a good thing to go sign up for a month-long trip in Sub-Saharan Africa or Latin America or Southeast Asia. You probably would want to know a little bit about where you're going, what you hope to achieve from it, and what that mutual relationship is hoping to do. Our sponsor has been established for over 10 years. We're going to try another video, but hopefully I don't screw this up.
Shoulder to Shoulder Global is a global health initiative that is operating from the University of Kentucky for over a decade. This is a great learning opportunity and life experience for our students. They get exposed to a new culture, challenges of providing healthcare in an underserved type of community. And you get to experience the joy of that service to others that frequently you don't get in the United States. These people value and appreciate the services that we offer, and they give us so much more back. They give us their trust, and they give us their love, and they give us their care. Students in all professions, particularly health professions, are welcome. We're now expanding to try to include as many colleges as possible at the University of Kentucky. And we're now reaching out to psychology, we've reached out to agriculture, social work, trying to get many types of professionals involved, because our ultimate goal is not just healthcare, it's provide relief from poverty and success in life in these communities.
During the whole brigade, PT, pharmacy, dentistry, nursing, we worked together so well. Each team would help each team whenever they needed, and regardless of if your station was here or there, you were always welcome to come and help or learn or also just observe. And that was very wonderful to be able to see what each team does and how they give care.
One of the most important skills we emphasize in interprofessional care is that you learn how to work as a team. We can no longer exist with a good healthcare system working in silos. So we learn how to work together, how dentistry can work with medicine, and how physical therapy is important for patients with back pain, not just the medicine. So we learn also respect cultural differences. We have a multicultural society, and in Ecuador we experience a unique culture, but we learn how to respect that culture, respect their beliefs, and still work in partnership and make a difference in their health.
Because I don't speak Spanish, I was a little hesitant going into the trip. However, working with interpreters on the trip was a very great experience. I learned a lot of skills about how we should communicate directly with the patient and use the interpreter as a guide for that, instead of speaking to the interpreter and having them relay the message. And I think learning skills like that, support working with language barriers, is very important because our country is getting a lot more diverse. And I think working with interpreters will become more common as the years go on. And I think learning that as a student was very beneficial to me.
Probably 4 years ago, we were having a medical clinic in a indigenous population called the Satchel, which we go to every year, 4 times a year, for over 10 years. We went to see this little boy who was 6 years old, who had never walked, who had never talked. And was told when he was born that take him home, he's just going to die. So we were able to bring in our interprofessional team, the physical therapist, work with our Peace Corps volunteer, work with the local clinic, and get this child seen. And it turned out the child was just having seizures. It was at a week of medicine, he was walking. And he continued to walk ever since. Being there, having an interprofessional team, having a permanent clinic, and a team to make a difference, how we can change the life of a child at a time. My thought process is, I hope this has been a life-changing event for those students. And they'll take what they've learned, what they've experienced, and reflect on it, and decide how they can make a difference in others' lives, and to make a difference in other people's lives, to make a difference in your own life.
Then Tom had started that interest, Dr. Young, that program with just an interest in wanting to help people. And some of the alignment with Ecuador came with some of the kind of Great Society partnerships when the Peace Corps and the United Nations came in. One of the linked Latin American countries to Kentucky was Ecuador. So that is why that helped. And so there was always that infrastructure. And as David was saying, we go to Ecuador. Typically, Atlanta will have direct flights. It's about a 4 to 5 hour flight. They're in the central time zone. It's pretty easy to get through. We fly into Quito. The other bigger airport is in Guayaquil. And then if you look at population centers, Guayaquil is the largest with over 2 million. Quito has over 1 million people. And then Santo Domingo, where we go, is actually the 4th largest population center. And that's probably relative to its proximity to Quito and its also geographic destination between Quito and the coast. If you look at kind of Quito, Santo Domingo, and then I keep hitting the wrong arrow, it will, you know, have a feel to where you will see, as David was saying, some more paved areas. This is actually a shopping mall that we take students and residents to at the beginning of the trip to buy groceries and different stuff. It has a movie theater, but within eyeshot, you will see mixed construction and people who are very impoverished. It is an area that we sometimes worry about safety. So we have structured things to where it's in groups. The physician down there will say that, you know, our patients will mug you, but I think he just jokes, but it could be true. I've never been mugged. You will see that it's generally hot and humid most of the year. And then this is the typical kind of mixed road, rock, dirt kind of thing. But when you get into the city itself, you will see several hostels. They have areas, they have some local healthcare delivery systems. This was a unique year because of COVID. This is the line for a second vaccination for the Pfizer product. This is one section of it. It stretched for, I think, over 6 city blocks. And when we looked at the health precautions for brigade participants, we thought a lot of our preparation, but then Ecuador was still at a level to where it was a level 3 on the whole travel for COVID, and the population had seemed to embrace masking and some of the campaigns. Now, of course, that's not universal. And the enforcement in Ecuador was a little bit more substantial with mask enforcements and fines. If they caught you without a mask, they would fine you. And if you were out of country, it wasn't worth the conversation with local enforcement agencies on why you didn't have a mask. So it seemed that they had a handle on things. The Satchela people are the indigenous to the area. The province is named after them. As David was saying, they have unique clothing. In the painting to the left, you see more of what it was like even 50 years ago. Both genders did not wear tops. They were identified from their bottom garments. And then you see this interaction of colonial populations and other mestizo or Inca populations with the Satchelas. They speak a distinct language called Safiki. It is a unique language in that it has no written form, it's only spoken. And there's only a little over 2,000 Satchela native people that identify as Satchelas left in the country. So it is one of those things to where if you do have an older Satchela patient, you will have 2 interpreters, one from the community to translate Safiki to Spanish, and then somebody to translate Spanish to English. So it is a unique and a life-changing kind of thing. If you do go on one of these trips, we provide educational materials. You can even offer to help update some of these manuals that we use. The latest edition that we were using was pre-COVID. We have strict protocols for how we want you to prepare, who's responsible, who tracks it, and then there's COVID-19 contingency planning. So as long as we have a pandemic, you will be well taken care of, and we will ensure that we will make every effort to comply with CDC and International World Health Organization guidelines. This is a typical schedule, as David was saying. You'll see that some of these things, El Bula and Los Naranjos, are my butchered kind of Spanish or Safiki, but those are Satchela communities There's 8 communities, 3 are very large, as David was saying. We go to the 3 large ones. Laura Flores is a impoverished neighborhood in Santo Domingo. And then our health clinic is the CSHH. We do send pediatric groups to an orphanage. We send them to a rehabilitation center, and we send people to home visits. And it's very organized in a way that where you go out in the community, you're going to go out with a physical therapist, you're going to go out with a nursing professional, you're going to go out with appropriate translation services. And then sometimes we have large brigades and we will send you off. Like David was saying, these are houses that you'll go in that have no actual partition from room to room. They have no floor. They have chickens walking around, whatever animals, dogs. And then you will have someone that has an acute illness like chikungunya or dengue, and then you will try to educate and help with that. But it was one of those things to where we take care of the participants in a way that I think is safe, educational, and leaves a lasting impression when you come back. We wanted to kind of leave the rest of the presentation for the last 5 or 10 minutes for any questions that we might have glossed over, or to have you let us know of any interest that you might have as we work to increase our global health experiences. This is one program we thought it aligned well with our educational missions for students and residents. And we have good coverage with how to work with the Ministry of Health in Ecuador, how to make sure liability is covered, lodging, transportation. There's many opportunities out there, so make sure that you do have a well-researched plan when you go on one of these opportunities, and make sure that things are well thought out and all the logistical information is covered. So with that, I'll kind of stop and let anybody ask any questions that they might have.
There is a question in the chat. Shoulder to Shoulder Global is a University of Kentucky-based organization. What are the barriers to forming a similar organization within the University of Tennessee School of Medicine?
It would be one of those things to where you would start from scratch. The University of Tennessee Health Science Center, the question was, what are the barriers of starting a program with the UTHSC? It would be one of those things you would need an organized multi-campus kind of approach, and there would be some heavy lifting logistically. So it would take someone with passion and interest, and it would take someone that had the ability to fundraise and have some money. It would be a full-time job, I guess is what I'm saying.
And in fact, there is, we didn't mention, but somebody who's very key to this whole thing working is a guy named Craig, who is a character, but he's awesome. And he is employed full-time through the University of Kentucky to manage these 3 brigades that go, and enlisting the people, making sure all their documents are done correctly, making sure everyone's paid, make sure everyone's travel and transportation set up. So it is a full-time job that would have to be a part of.
And we have
that mission to make it happen.
And we have a coordinator on site in Ecuador in Quito named Pablo that will help with a lot of in-country things. And then the clinic is staffed. The physician's annual salary in the clinic in Santo Domingo is $24,000 American dollars. So that is the kind of amount of resources that we're having. But the clinic is staffed throughout the year. It has nursing and has the ability to deliver preventative services, dental services, and different things. So it could be formed in a similar way. It would just take coordination, time, and a lot of effort, and some dedicated people that could work together. We thought instead of building it from scratch, it would be better to align and continue to expand with what we were hoping to do educationally for the residents.
I think it maybe grow into a partnership while it's growing until it's on full-fledged standalone.
And then they're welcoming any and all interested parties to help form that relationship.
I just want to say that COVID put a kibosh on the UT family practice, so we have a partnership with them as well. So they also have a trip that goes to Haiti and Ecuador, and we're hoping to get that reestablished with them. And our residents are welcome to go with our UTFP colleagues to these global health experiences. They're at a completely different place in Ecuador than where Dr. Carey and Dr. Sharon went, and then the other experiences in Haiti. I don't want you to have the fact that we don't have a formal global health large program like UK stop you from wanting to get involved in a global health elective. Your program leadership here is more than willing to explore other opportunities through other institutions where we can partner so that you can have that experience. So if you are from University of San Diego and you know that they have a trip coming up in May and there's faculty there that you know, just let me know and I will try to make the arrangements so that you can have that full experience. Just like we partnered with UK, and luckily we have Dr. Carey who goes on these brigades. We can also try to establish other partnerships throughout other institutions for you to have those different kinds of experiences. We just got the dates for next year's brigades. I'm going to be sending that out to you all. Dr. Carey for sure is going to go in August.
Yep.
But he's entertaining possibly going more if there's significant interest in the group. So I'm going to send out those dates to you, and please let us know as soon as possible so we can make appropriate arrangements.
Okay, you have questions?
Yeah, and Carla, I fully agree with that. Curtis, thank you for working on this. I think that developing these kinds of partnerships, even if we aren't in a position to set up something from scratch, there are lots of people we can potentially partner with locally and regionally. So I just know I'm fully supportive of this and just glad to continue in these discussions.
Dr. Woods was saying that he fully supports our endeavors and partnerships and is committed to this experience. We're technologically challenged, me being in the plural form, to not get that out to the room, but they were able to hear it. We have one in-person question. We had on-site interpreters, and then usually that is through an Ecuadorian medical school collaboration. So we'll have medical students that will serve as interpreters, so that way they can continue their experience in other areas of Ecuador that they may not be familiar with, and then we can collate that.
It was really nice. And their system is built more along the like English training. So they go right from high school into medical school, but it was really nice having them as translators because they could help kind of translate the meaning behind things and not just the exact word. And know what you're trying to ask and ask the question in a different way so that you can get the answer you're looking for. So it was really nice having some like medical, I mean, they weren't official medical Spanish interpreters, but they were. I mean, they would know all of the.
And then if you go on this trip, I'll help you to prepare with what vaccinations and prophylaxis and different things are needed. I don't, David did what you did.
I just did malaria. I didn't do any vaccines,
Yeah.
but you could do I think dengue has a vaccine. One of the tropical viruses has a vaccine.
There's not a yellow fever requirement for Ecuador, and you don't need a local clinic would need a yellow fever certificate. So the health department, different things, but you don't have to have a yellow fever vaccine for Ecuador. And I'd make a conscious effort not to be around at night when female Anopheles mosquitoes can inoculate me with malaria. So I will suggest that as well.
How many pediatric patients are you guys seeing today?
The average patient load, we have a unique system. We partner with the community and they sell tickets to show up. So there's a little bit of a engagement there. We budget the amount of visits for what providers we have. So if we have 4 or more pediatric providers, the open slots for pediatrics will be 40 to 80. And then the adults would be the same. David, you typically saw
anywhere from 10 to 20.
10 to 20 people a day. I tend to get all these adult things. or some. So I will see 20 to 40 in a day, depending on what we need.
So another thing that I want to add is that this is a growing field. And in fact, there are fellowships out there in global health. So if you are interested in making global health a significant part of the next chapter of your education, there are 1-year fellowships available, and there are all the way to 3-year fellowships available for those that are interested in making global health what they do for the rest of their lives. So if you have a significant interest in this, thinking that maybe you want it to be, a good part of what you do for the rest of your life, or you want to completely immerse yourself in global health, there are opportunities for additional training in this. So please let me know, and we will put you in contact with the right people. In fact, I just sent you guys yesterday or last night a global health fellowship that just came out. I think it's John Hopkins.
That was Boston Children's.
Sorry, Boston Children's, at Boston Children's. That one is a 3-year fellowship, but there are 1-year fellowships available as well.
And for those who want to do subspecialties, there's still opportunities for that as well. One thing that I really enjoyed when I went down there is obviously I did Gen Peds as a resident, but there's some attendings that go to different places, and depending what you want to do. For instance, I want to do critical care, and there is a couple attendings who go to different places around the world, and they basically teach kind of some interim stabilization type things, something in between a normal hospitalist like task and procedures that they would normally do, and some kind of bridge between that and getting to a tertiary level hospital where they can get better care, or like more invasive care.
And we've done programs to where residents can teach hospital staff in Ecuador that may be under-resourced. Helping Babies Breathe was a campaign that we have done with local populations, kind of nutritional alliances for pediatrics have been especially important. Good shoes and a sharp machete usually fix most musculoskeletal complaints that I see. So physical therapy and education have been quite invaluable.
So Dr. Carey, what if there's a faculty member that's listening right now? Maybe Dr. Moragle's listening here and says, how can I get involved? Or maybe there's a general pediatrician on our Zoom meeting. Can faculty come on these trips?
Yes, we welcome any interested party, and we will have private physicians, other faculty members with volunteer appointments or primary appointments coming, and we can coordinate through the center and Craig on getting all the information to you. And the cost is the same for anyone, $11.95. And then typically, if you book your Delta flight out of Atlanta, you can get a flight under $500. And if you want a regional connector, if you book it right, you can still get it under $700.
Tax deductible.
Yes, and you can use some of these expenses in conjunction with your CPA or tax professional on how to do this. Well, we appreciate everyone listening to us, and hope they have a good day. And I especially want to thank all the pediatric residents and the faculty for allowing me to be part of this department. It has been a life-saving experience for me at Erlanger. So thank you so much.